A very good evening to all of you all. Welcome to Wikasepedia. Today I have with me Dr. Gautam Zaveri, who's an eminent spine surgeon and also the organizing secretary of WIROC 2019, who's going to tell us more about what Wikasepedia is all about and is also going to be presenting the first case in this series. Welcome, Dr. Gautam Zaveri.
Thank you, Swapnil. Welcome to WIROC 2019. WIROC, as all of you know, is the premier orthopedic conference of the West Zone. And this year, it is going to be held between December 20 to 22 at the Renaissance Convention Center in Powai. We have an excellent academic program for you, which includes Meet the Masters sessions, WIROC symposia on surgical site infections, unicompartmental knee replacement, as well as reconstruction of elbows. But along with that, we have a lot of individual interactive case discussion sessions at WIROC, which will enable you to interact with the faculty in terms of discussing cases and learning from them. Just to showcase how WIROC is going to work out this year, we have started this series called the Wikasepedia for WIROC. In this, eminent faculty in various streams from across the Bombay Orthopedic Society will discuss an interesting case with something which will be useful to you in private practice and tell this is the type of cases which will be discussed at WIROC. So without much ado, let me begin with this first case on spine. This is a 25-year-old lady. She came or presented to a spine surgeon with severe back pain for 2 months. There was a history of weight loss, anorexia, and low-grade fever. On examination, she had tenderness over the lumbar spine. Movements were severely painful and restricted. No neurologic deficit. She had lost 7 kgs in the last 2 months and presently weighed 35 kilograms. These were her X-ray pictures. As you can see on this X-ray over here, there is a partial destruction of the vertebral bodies between L1 and L2. As you can see on the lateral view, there seems to be a reduction in disc space. Moving on to the MRI, you can see there is a pathological fracture of the vertebral body over here. There seems to be some involvement of the disc space over here, but can't be very sure. And there seems to be some retropulsion of the posterior wall of the vertebral body, which is involving a soft tissue mass over there. A total count was 6,500. The ESR was elevated at 70 millimeters. CRP was 1:4. The tuberculous IgG and IgM were elevated, and the Mantoux test was 10 by 10 millimeters. The question now in front of the spine surgeon was, how should he proceed? Should he do other investigations? Is it necessary to do a vertebral biopsy when it seems to be obvious here that this might be an infection? Should he start an anti-tuberculous treatment directly over this patient for this patient, or should he think of surgery? Well, the surgeon concerned started the patient on an empirical 4-drug anti-tuberculous treatment without doing a biopsy. I got involved about a month later when I got a call from the family that she had persistent severe back pain and overnight she had developed complete paraplegia. I took this patient up for surgery within the next 6 hours. This was the X-ray picture at that time, showed a further destruction of the vertebral body with a deformity developing in this region over here. The MRI essentially showed a similar picture to what it was about a month earlier. I operated on her, excised the vertebral body anteriorly, reconstructed the anterior column, and even did posterior instrumentation. Unfortunately, the pathological report which I sent for showed lung cancer with metastasis to the spine. This lady died with paraplegia about 3 months later. A very sad story. Something which could have easily been predicted if a biopsy had been done in this case. So my question to you is vertebral biopsy. Why, what, and how? Why should you do a biopsy in any patient? The first reason is you want to identify pathology. Sometimes what you think is infection, like in this case, may turn out to be something different. Or sometimes you might think of a tumor, as in this case over here, which may turn out to be tuberculosis. So you need to differentiate infection from other pathologies which may cause vertebral body involvement. Even if it's an infection where you can see an abscess, you want to differentiate it from tuberculosis from other infections. 5 to 10% of all infections will not be tuberculosis. They will be pyogenic, brucellosis, fungal infection, salmonella. And this is even higher among patients who are diabetics, patients on renal dialysis, transplant patients, all of which we are seeing more and more today. Let me give you this example of a 26-year-old boy who had no comorbidities. There was pain in the left buttock and fever. The MRI showed a large sacroiliac abscess, which is presacral and involvement of the sacroiliac joint. The total count was 16,300, ESRs 90, CRP 1:24. We drained the abscess and the culture grew E. coli in a 26-year-old male. So sometimes you can get surprised, and that is the reason why a biopsy will become so essential. Another reason why biopsy must always be done, even if you think this case is tuberculosis, is that it helps you to identify drug resistance. In 2016, about 500,000 new MDR tuberculosis cases were reported worldwide. India is a high burden country for MDR, and the incidence is almost 13% in India. Primary drug resistance in patients who are virgin as far as anti-tuberculosis drugs are concerned is about 4%. Secondary drug resistance is 21%. And that's another reason. Now, once you decide that, yes, biopsy needs to be done, what sort of biopsy should you think of? There are various ways of doing a biopsy. You could do a percutaneous biopsy, an endoscopic biopsy, or an open biopsy. Open biopsy is usually done when surgery is anyway indicated, like in the patient whom I operated. By that time, she was paraplegic, she needed surgery. So we did a surgical surgery and at the same time sent the material for histopathology and microbiology. The most commonly done biopsies are percutaneous biopsies. In order to do a percutaneous biopsy, you need to guide the needle to the area of where the lesion is. And to do this, one requires either fluoroscopy or one can use CT guidance, ultrasound guidance, or rarely an MRI guidance is also possible. Whenever you're thinking of percutaneous biopsies, you can do two types of biopsies. There are core biopsies and what is known as a fine needle aspiration cytology. What is preferable is a core biopsy. It is done using a vertebral biopsy needle, what is called as the Jamshidi needle, which is 10 gauge or 11 gauge needle. The biopsy can be done under local anesthesia. And what is obtained is a cylindrical core of bone. Multiple cores are obtained from various directions. And the advantage of a core biopsy is that it gives you a higher diagnostic yield. The FNAC, on the other hand, is done using a thin biopsy. It allows procuring limited tissue, which is mainly cells which are obtained for cytology, and the diagnostic yield is poor. It is useful when you are aspirating pus or biopsying paraspinal soft tissue masses, but for dry bony lesion, an FNAC may not be a very good idea. Finally, how does one do a biopsy? It is done, a fluoroscopic guided biopsy is done in the operating theater under local anesthesia or sedation. The anesthetic stands by, an IV line is established, oxygenation is started. Positioning is such that the images can be obtained in both the anterior, posterior, and lateral views. In the lumbar spine, we try and do a biopsy either most commonly through the transpedicular route, or if necessary, we can take an extrapedicular paraspinal approach. On the other hand, in the thoracic spine, one again up to around T67, one still tries to do a transpedicular biopsy. As you go higher up in the spine, the pedicles become narrow and the chances of successfully cannulating it is much lower. And therefore, an extrapedicular biopsy may be done. The biopsy, having seen the pedicle, local anesthesia is infiltrated, a stab incision is made, and a K-wire or the bone biopsy needle is introduced starting at the lateral border of the pedicle. And from here in, the needle is introduced into the pedicle. You keep on introducing the needle till you reach the posterior surface of the pedicle, of the vertebral body, at the end of the pedicle. When you reach that posterior surface of the vertebral body, at that time, the needle should be lateral to the medial wall of the pedicle. If it is medial, that means you have perforated the pedicle and you are going to go through the spinal canal and may injure the nerves. How does one improve? Often biopsies from the spine come out to be negative. How does one improve the diagnostic yield of biopsy? One, do not administer antibiotics before you obtain a biopsy. A core biopsy, as I mentioned, is much better than a FNAC. You do it with a wide bore needle. Take multiple cores from the central of the lesion, from the margins, aspirate bone marrow fluid, and even send it for testing. Soft tissue masses are more likely to yield positive results than bone. Granulation tissue is more likely to yield positive culture than pus. And therefore, when you aspirate, do not aspirate only pus. Try and get some granulation tissue to send for histopathology and microbiology. Obtain biopsy. Plan your biopsy. Obtain it from the area of maximum destruction. Often, people go very early and target the hyperintensity signal on the MRI scan, which is nothing but an inflammatory bone marrow edema. And then in these cases, often the biopsy turns out to be negative. Remember that lytic lesions are more likely to yield positive results than sclerotic ones, and that patients with a high CRP and positive blood cultures are more likely to yield a positive results. What does one do with this biopsy material? That is extremely important. As a routine, we send it for histopathology and for microbiology. In microbiology, at least in the Indian subcontinent, we send it for gram staining as well as Zeal-Nielsen staining, so that a smear is taken. And then we do a culture for tuberculosis, pyogenic infection, and in high-risk individuals, even a fungal culture is ordered. Finally, we also send some material for gene expert, because it rapidly gives you the possibility of whether the tuberculous bacilli is there, and if it is there, is it resistant or sensitive to rifampicin. So to conclude this case presentation, I would like to say, whenever you have a vertebral lesion, you must always confirm the diagnosis of tuberculosis before starting anti-tuberculous treatment. A CT-guided biopsy, which often is done by the radiologist and using a fine needle, which gives you a fine needle aspiration cytology, do it only if there are abscesses or soft tissue mass. Typically, a core biopsy obtained by a transpedicular route under fluoroscopy guidance in the operation theatre gives a much higher yield rate, more than 80%. Whenever you are sending material along with the pus, send tissue. Be careful to label your specimens. Send them for histopathology and microbiology. Microbiology involves 3 tests. There is a smear, which is for pyogenic organisms as well as for tubercular organisms. You do a culture for pyogenic tuberculosis and fungal cultures. And finally, you do a gene expert to rapidly procure the organisms, as well as to find out if there is a resistance to rifampicin or not. Thank you very much for patiently listening to this case discussion. Again, I take this opportunity to invite one and all to the YROC 2019, December 20 to 22 at the Renaissance Hotel and Convention Center. This is going to be a grand event, a great academic occasion, and I'm sure you will not want to miss it. Thank you.
Thank you very much, sir. That was indeed an eye-opener. I thank the audience for the patient listening, and I would also request the audience that more such Viroc Wikasepedias are coming. So be prepared and have a wonderful evening. Thank you.